Hello and welcome to the lecture on medication delivery, and this one is specific to people that are on some form of mechanical ventilation or breath support. So this one will be a little bit different. The big thing is not only what are some considerations when we're looking at delivering a medication to these patients, what do we do with the ventilator? Do we do anything with the modes? Do we do anything with the settings? Should we do anything with modes? Should we do anything with the settings? What happens if we use a regular small volume neb in line with a ventilator? What happens if we use an MDI? So on and so forth. So we're going to look at a lot of different considerations here. So let's get started. So let's just talk about this. When we're looking at doing an aerosol in line with mechanical ventilation, make sure you take out the HME, a heat moisture exchanger, if they have one. The heat moisture exchanger traditionally can develop or not only block medication delivery if it's downstream from the nebulizer, but it can also retain some of the medications, and it can eventually cause an occlusion there too. So make sure that the HME is taken out if there is one, if you're going to nebulize anything through that circuit. So that's a big point. If you're wondering why your patient's not getting all the medications that they're supposed to be getting or not having the response you expect to have with medication delivery, did you do something like leave the nebulizer in with the HME in at the same time, right? So that's something you got to look at there. Do I have an HME in place? Could that be blocking the ability for the medication to get in there? Know the therapeutic goals of the medications. So that's this next point here. Know those therapeutic goals of the medications. Why are we doing this medication? Is it for airway clearance therapy? Is it to thin mucus? Is it to increase ciliary motility? Is it to bronchodilate? Is it to pulmonary vasodilate? Right? What is the indication, what is the goals for the medications that we're about to deliver, because that might help you make a better plan of a better way to administer that. So things that we look at are things like bronchodilators, very, very common. The most common medication given to someone on mechanical ventilation is going to be a bronchodilator. So it's not limited to those, but that's the most common one you'll see, especially with respiratory patients. A lot of times that's what we're looking at giving to them. Inhaled corticosteroids, right? Inhaled corticosteroids are another one where we could nebulize or do other methods there. Antibiotics, nebulized antibiotics, especially for patients with infection processes. Mucolytics to help thin out secretions. There are other drugs that can do this that aren't nebulized. There are other drugs that we can look at there too if we need to. And then finally, surfactants, right? So we'll start talking about these. The most frequently used drug that's administered by aerosol to a vent patient is the bronchodilator, right? The most frequently used drug administered by aerosol to a vented patient is a bronchodilator. And that is primarily secondary to the effects that it has on the lungs. When we're looking at the sympathetic effect, and usually they're sympathomimetic, some of them include a parasympatholytic, or an anticholinergic, like an Atrovent. But traditionally with Duoneb, albuterol, Atrovent, they will stimulate the ability for the airways to open up a little bit, which helps with movement of gas in and out. So it might aid in ventilation and therefore subsequently aid in oxygenation. So that could be a potential benefit. So what are the harms with that? Well, we'll talk about that a little bit later, but you could see an increase of heart rate. You could see mucus plugging where the secretions could dry out, right? It just depends what's going on with the patient's pulmonary pathology. There are some studies out there that talk about bronchodilators increasing ciliary motility, or helping the ciliary beat, or helping that mucociliary escalator bring secretions forth. But are there other methods to help with airway clearance therapy besides bronchodilators? Of course there are. So understanding your therapeutic goals for these medications can be very helpful. All right, some factors that we should be looking at. The type and placement of the aerosol generating devices. So the type and placement. So if it's a small volume neb, where do we place it? Do we place it proximal to the ventilator circuit where the the ventilator machine is pushing out the medication, or do we place it proximal to the patient, to their artificial airway, whether it's a tracheostomy tube or an endotracheal tube? Where do we place it where it's going to be the most appropriate? So that's something we have to look at, the type and the placement of whatever we're giving. We talked about in the other humidity and aerosol PowerPoint, the humidity about having a meter dose inhaler proximal to the patient, right? If you're doing an MDI, well, we need to know what we're using this time and then where to put that adapter where it's going to be most effective for that patient. The other thing to look at here is going to be ventilator mode and settings, especially trying to time MDI with a patient that's spontaneously triggering all their breaths can be very difficult, especially if they're breathing very rapidly. Getting that proper timing is a huge thing if you're doing an MDI with a vented patient. So we need to understand what mode and settings we might have to change. What if we're doing a small volume neb that's pneumatically powered? We're using a nebulizer and we're turning the gas flow to 6-7 liters a minute. What happens to their ability to trigger a breath? What happens to their tidal volumes? What happens to all their patient interaction with the machine when we start adding extra flow to the circuit without the ventilator knowing we're adding that extra flow to the circuit? There could be a lot of stuff. What happens to the heater, right, when we're adding that extra flow to the circuit that's cold gas? Is there more rain out that's occurring and causing triggering issues, right? So there could be a number of things that we got to look at here, so we're going to dive into those. The other thing, how severe is this patient's condition, right? How severe? Sometimes we do have to break the circuit to get these adapters in place, and so you got to make sure that not only you're timing it at end inspiration, but to put it in those things, but you're also making sure that you're trying to limit as much circuit breaks as possible, especially if they're in a very restrictive disease process like ARDS, where they can de-recruit their lungs very quickly. So the severity of their condition can play a factor here. The nature and type of medication is going to be very helpful to understand if we're giving a pulmonary vasodilator nebulizer, right, versus anything else. So that's going to help us understand, okay, is that something that we need to use a different concentration of gas for, right? The type of medication and then the gas used to deliver it. If a patient is on room air, let's say it's a little baby that's very oxygen sensitive, that's a newborn, right? A neonate, and they're very oxygen sensitive. Do you want to use 100% oxygen to deliver that nebulized medication to that baby who's on room air on the ventilator? Probably not, right? You want to use blended gas. You want to make sure that you're going to use the right gas source to deliver that medication, right? Same thing if you have a patient that's on 100% oxygen. Are you going to pipe in room air to drive that nebulizer to that patient who's on 100% oxygen? You're going to dilute how much oxygen they're getting, and it could cause a lot of bad results. So we ought to understand what's going on with the situation. There's a lot of dynamics that didn't come into play in just a regular floor patient, but now we got to consider those when we add life support to this whole picture. All right. What about indications, right? Bronchodilators with mechanical ventilation is indicated for the treatment of bronchoconstriction. That should be a straightforward one. Hey, you got a patient that's wheezing, asthma exacerbation, COPD exacerbation, and they're having a hard time on mechanical ventilation. A bronchodilator is indicated. In fact, there's a lot of board questions that will ask where a patient is wheezing on mechanical ventilation, and they're looking at having you go ahead and nebulizing a bronchodilator medication. What about increased airway resistance? This is that next part. And you'll see that with bronchoconstriction as well, right? Increased air resistance can be caused by bronchoconstriction. So therefore, we should owe it to the patient to consider a bronchodilating medication, right? If we see an increase in airway resistance, the bronchodilator could help in that situation, especially if there's a bronchospasm effect. What if the patient's just regularly not in a bronchospasm and we see the raw go up? Could it still help? In theory, it could. If it has a sympathetic response, even though they're not in bronchospasm, listen to what I'm saying carefully here. Even though a patient's not in bronchospasm, where the airways are completely closed down, the airways, let's say at their normal radius, right? Their normal radius. And then we give them a bronchodilator medicine. What happens to that radius? That radius does increase as long as they're responsive to it. So therefore, is it easier for gas to get in and out? Absolutely. Right? If you go back to Posey's law way back when about the radius to the fourth, an exponential change in the pressure and flow happens when we just barely make a change to the radius of a tube. So that's what happens here. So even if they're not in bronchospasm, could a bronchodilator help them effectively ventilate better and subsequently cause better oxygenation? It could, right? So it's something that we can look at. And with anything in critical care medicine, we're looking at risks versus benefits here. And what are potential risks with this patient compared to the potential benefits? And if bronchodilators have more benefits than risk, they might go ahead and elect to do that. What about the history and physical assessment findings? This patient has active wheezing. They have high airway, high raw airway resistance. They're are working hard to breathe. They have a history of bronchospasm. They have a history of asthma. They have a history of COPD that includes a broncho reactive response, right? So those would be indicators to go ahead and continue that therapy or start that therapy while on mechanical ventilation. So the decision is made on history and physical findings, such as COPD, asthma, and wheezing. So put your COPD, asthma, right? Put that in there. And then this one would be your wheezing, right? Your wheezing. So if the patient has an active history of COPD, asthma, and or wheezing, then that patient could be indicated for bronchodilators. And this is something they want you to look at on your patients on the board exams as well. So they'll ask you about that. Can the ventilator graphics support the need for bronchodilation? Yes, absolutely, right? And we talked about that in our graphics PowerPoint. So if you haven't looked at that, go ahead and go look at that PowerPoint video that I did on the ventilating graphics. So you'll see a dip in their flow rates, right? Their flow rates go down just like in pulmonary function land. They'll have decreased flow rates. And not only that, but it's going to take a lot longer time for them to exhale back to the baseline pressure or the baseline flow, right? So it's going to take a long time for them to exhale. They'll have slow lung units. So can we see this on the ventilator graphics? Of course we can, especially if it's the flow volume loop. Hey, we look at flow volume loops in pulmonary function testing, right? So the flow volume loop is going to be one of our best friends for these obstructive disease patients. Because can you still see scooping on a flow volume loop on a waveform on a vented patient? Absolutely. Exhalation is passive, so therefore we can see scooping still. What about on the flow time scaler? Yeah, on the flow time scaler, we can see their peak expiratory flow rate is very small. We can also see it takes a long time for them to get back to baseline. And so therefore we could see on there, hey, they might need a bronchodilator medicine and or to change the rate to slow things down to give them a longer time constant or to increase their peak flow. Right? We talked about this before with COPDers. According to the book, if you're doing volume control ventilation where you control the flow rate, we usually want to start at a minimum flow rate of 60 liters per minute in order to make sure they have an adequate expiratory time constant. What about AARC, the American Association for Restorative Care? What do their clinical practice guidelines have to say about this? Well, they say for an increase in airway resistance or bronchospasm, you should consider nebulizing or giving a bronchodilator of some sort. It is considered contraindicated in high auto-PEEP or long inspiratory pause situations because you could be adding more flow or more pressure to that patient, which could cause a detrimental cardiovascular side effect or pulmonary side effects such as barotrauma or volutrauma. So that's what they're looking at for that. You're like, hey, they have a lot of auto-PEEP because they're air trapping. Well, let's try to fix that. And maybe if it's a bronchospasm thing, maybe we need to figure out what's causing it and work the cause. If it's massive inflammation, then wonder what would happen if we give this patient systemic corticosteroids. And we'll talk about a lot of this pharmacology approach when we get to advanced pharmacology. So a whole nother class, but stick with me for then, right? Because then we'll talk about why your continuous nebulizer patients may not break until the systemic steroids kick in. Why not? Why don't the beta-2 receptors accept it? Well, a preview here, beta-2 receptors aren't going to be very sensitive until the inflammation goes down, right? So systemic steroids really going to be helpful, right? Well, what are some complications, right? We're on this third bullet point here. What are some complications of doing this, right? So the device or the technique might underdose the patient. So let's go back to my example of a patient using an inhaler, right? We're trying to time an inhaler with a ventilator breath, right? You're in there, you see the patient start to trigger breath, you give the puff, right? But you puffed too late. You gave the puff just as the inhalation was finishing. So how much of that medication got delivered to their lungs? Probably not much. Okay, you're like, I got it this time. So you shake it, right? You're getting ready. You're shaking the MDI, right? That's what I'm talking about by shaking it. Right? Get your minds out of the gutter, right? So you're shaking the MDI, right? You're getting ready. Okay, you're ready for the next dose, right? You're ready? So you're going to do the next puff, right? And then all of a sudden you see the ventilator start to deliver breath, and then you start to, oh, I didn't have it seated the right way, but some of it got in there. Oops. Right? So the medication and timing can be an issue. So you could easily underdose. That's why MDIs, usually we double the dose for mechanical ventilation patients. So traditionally, like an albuterol inhaler is a 2-puff dose, but we're going to go ahead and order for 4 puffs. So traditionally, that's a doubled dose just to make sure that we got the right way of getting it in there. So the device or the technique, the device as well, might underdose, especially when we're looking at nebulizers, if we're having it where we don't place it in the correct placement in the circuit, that could easily underdose or cause not much of that medication to really be delivered. The device itself, which is this next point here, the device itself may compromise the integrity of the vent circuit, right? So we're creating an extra part of that circuit, so it could be causing a situation where could it become disconnected? Could it be a source of infection whenever we break the circuit? Absolutely, right? So the circuit integrity does become an issue when we're looking at this. Systemic absorption causing hypokalemia and dysrhythmias could be a potential with this because the positive pressure ventilation is driving the medication. We have more, in theory, we have more inertial impaction as the medication is getting forced and delivered there. Forced. We might have better systemic absorption, which is not always best because this medication is designed to be topical. Whenever we nebulize, we're looking at topical absorption traditionally, and this one, it could have more side effects because we have more driving inertial impaction that could send that medication better into the capillary network and cause more side effects, right? So that's something else to look at. And when that happens, especially albuterol, things like that can cause hypokalemia. Well, hypokalemia can cause dysrhythmias. Tachycardia can cause dysrhythmias. Can tachycardia be a side effect of a sympathetic stimulating drug? Yes, absolutely. So there could be more potential side effects with PPV. The other part here that you got to consider, what gas are you using to deliver this? If you're giving that cold, dry gas that you're nebulizing from the hospital oxygen, right back there, you're using that cold, dry gas, and you're setting it in line with the heated, humidified circuit, right? That cold, dry gas could cause mast cell destabilization and then cause a bronchospasm and cause issues there. So that is another thing. You could be potentially causing harm using that cold, dry gas if you're nebulizing. What about the alarm sensitivity, right? How does the ventilator deal with having all this extra flow rate if you're doing a small volume neb? If you're doing a small volume neb and you're adding 6-7 liters in of flow rate from a small volume neb, you could easily see, hey, high pressure alarms, or that's running an extra flow rate, and it's not going to allow the patient to trigger the breath as easily because now they have to overcome that 7 liters, plus let's say you have a flow trigger of 2 liters. Now they have to do a trigger of 9 liters per minute to get that breath, right? That's a huge pull. You're asking the patient to do a lot of work just to trigger spontaneous breath while the nebulizer is running. So that's something you have to look at. Is high pressure alarms, oxygen alarm, FiO2 alarms, right? We talked about that in a whole separate PowerPoint, and then even trigger sensitivity. Adding the gas flow here, this last part here, especially for small volume nebulizers, pneumatic small volume nebulizers, adding that gas flow might increase their tidal volume, their flow rates, it might increase their peak inspiratory pressures, it might change their breath patterns, it might change the amount of oxygen that's getting delivered to the airway. So there's a lot of complications that can go on with this. So like what I was saying earlier, risks versus benefits. Where are we at with this patient with doing a bronchodilator? Are they sensitive to cold, dry gas, right? Is there something else we can do where we don't have to do that? Maybe that's a switch to an MDI. Right? Maybe we're doing something like a vibrating mesh nebulizer where we run it through the heated circuit and we don't have to worry about the cold, dry gas, right? So there's other ways you got to look at what are potential risks that we're looking at, and then what happens to our breath delivery with a pneumatic nebulizer versus something that doesn't add flow to the circuit, like a vibrating mesh nebulizer, right? So these are things you need to be paying attention to if you want to give the most optimal care to the patient. All right, so what types are out there? Pressure MDIs, pressure meter dose inhalers, is the first one here. So MDIs have been a very popular option here for a long time, and some of this is regional. It depends on the facility that you're going to and what the pharmacy and what the respiratory therapy department and the critical care intensivist and what they want to do as far as how they want their patients dosed. So it could be any one of these options. So this might be regional, but you should be prepared to do any one of the following when you're looking at this. So MDIs is out there. The big thing is making sure you put it in the right place in the circuit and that you're timing it well and you're doing the appropriate dose. The next one on there is nebulizers, so nebulizers, and that's a broad category. So let's start with this next one, small volume nebulizers. And traditionally, these are the ones that are pneumatically powered, right? You run it at a flow rate from the wall at 6-7 liters per minute, whatever the manufacturer recommends. That's appropriate for that type of nebulizer. Right, that's where you're adding extra flow, cold, dry gas, changing their FiO2 potentially if you don't have a blended gas source, right? All that stuff could be going on. Ultrasonic nebs, you don't see them as often anymore, but that is another option. Vibrating mesh, more and more popular. One of the more popular ones out there is called Aerogen, but these ones don't add any extra flow to the circuit. They can be set up to go continuously. These are pretty neat little devices. The next one here is to make sure that you understand that ultrasonic nebs and vibrating mesh nebulizers will produce smaller particles, right? They do produce smaller particles. So you're going to get more depth, more deposition, if you will, to smaller airways of that medication. So that should help for those airways that are very distal, that could be impacted by the bronchospasm, that could be impacted by whatever we're nebulizing it for. Especially if we have a very bad pneumonia and we're doing a Pulmicort nebulizer, right? We need to have a smaller MMAD, a mass medium aerodynamic diameter, right? We need to have a smaller MMAD for that because we need the area that's inflamed, which is more the transition and respiratory zone. We need that area to get most of that medication. Well, if we're using an ultrasonic or vibrating mesh nebulizer to do it, we're going to have better deposition. We're going to have more of that medication go to where it needs to go, closer to that transition and respiratory zone. The other advantage of the ultrasonic nebs and vibrating mesh nebulizers is they do not add gas into the circuit. So that helps us big time, because now we don't have to worry about trigger insensitivities. We don't have to worry about diluting their FiO2 if we're using room air, or adding FiO2 if we're worried about causing an oxidative lung injury or any issues with their eyes if we're adding high FiO2s for oxygen sensitive patients like neonates, right? So those are advantages of using the vibrating mesh and the ultrasonic nebulizers. Deposition really does depend. Deposition rates with nebulizers, look at this, 1.5 to 15% with nebs. Deposition rates, 1.5 to 15%, right? You can check that against the chapter. I promise you it's in there. Not great. But with MDIs, check this out, anywhere between 2% to 98% deposition rates. Why such a swing there? I promise you that's in the book. Why such a swing there? Hey, that's all about technique and timing, right? Technique and timing. So you could get much more deposition in theory with an MDI if you have the right technique and timing with it compared to a small volume nebulizer. But if technique and timing aren't consistent, then you'd still be better off in theory going with the small volume nebulizer. All right, so what are some of the different things that we have to be considerate of? And you'll see this in the PowerPoint, right? You'll see this in there. The ventilator related issues are the mode of the ventilation there. Are they in spontaneous mode, pressure support mode? Are they in a full support mode, partial support mode? Are they in a mode where their breathing is not uniform and deep, right? That will affect deposition. What's their tidal volume? Is their tidal volume already big? What are their pressures, right? Could they have an increased peak inspiratory pressure with nebulizing using a pneumatic nebulizer? Absolutely. Respiratory rate, their cycle, the waveform that you're giving can make a difference at how that medication is delivered. And even their breath triggering that we've already talked about, that sensitivity, could be a big factor for using a pneumatic nebulizer. And also the device that we're looking at. Is it an MDI where we have to make a spacer and adapter close to that patient? So that means we have to break the circuit. We have to have good timing on medication actuation. We have to make sure it's placed appropriately in the circuit. And notice this one is back from the Y. So here's the Y here where it connects to the patient. And it's back from there on the inspiratory limb. Right, don't put it on the expiratory limb. I shouldn't have to explain that, and I won't. But on the inspiratory limb, of course, that's where you'd put that spacer. Well, did you do a short self-test when you added that extra circuit spacer? Because what happens to the compressibility of the circuit when you add that spacer in there? Right? That could change, right? With nebulizers, the type of nebulizer used, is it pneumatic versus a vibrating mesh or ultrasonic, right? Is it a continuous nebulizer versus, hey, just intermittent once every 4 hours or so? How long does the nebulizer last? Is it 10 to 15 minutes? Or is it one of those hour-long nebulizers? Where is that positioned in the circuit? Is it proximal to the patient, or is it back at the ventilator output itself, right? So things like that could change things. Even when we're looking at the circuit down here, the circuit, is there humidity on the ventilator being used? If not, we need to take out the HME, right? Take out the HME, so you're breaking the circuit for that, which could be potential loss of air causing atelectasis, potential risk for infection, breaking the circuit, because eventually you're going to have the nebulizer or MDI end, and then you're going to have to put that HME or a new HME back in. So you're breaking the circuit twice, right, with those HME patients. The humidity, if the humidity is high, what happens to the ability to carry that water, right? It could have the potential to rain out. In other words, some of that medication could be blocked and the patient may not get as much medication. We'll talk about that. There's a little controversy there. Drug-related, the aerosol particle size, the duration of action. So there's a lot of stuff that we have to look at. What's the patient positioning in, right? So we're going to have a lot of factors that go in here. Like I said, this gets more dynamic when you add life support into the picture. So let's sort of talk about these. So let's talk about the ventilator factors. So vent factors that influence aerosol delivery. One of the first ones that we'll talk about here is the mode. what mode is my patient in, right? If they're doing spontaneous breaths, they're considered to be better than mandatory breaths. Why do you ask that, right? Why is that better, right, Derek? If my patient is in a spontaneous mode where they're triggering the breaths, or a pressure support mode where they're using their patients doing most of that work, why is that better than if the machine's forcing the gas in? Why? Well, when you breathe, this goes back to the physiology of breathing, you're using your diaphragm to pull gas in. You're using negative pressure. When you're using your diaphragm, when you're using negative pressure, you have more even gas distribution throughout your lung regions. So with that even gas distribution, you're going to have much better particle deposition, much better distribution, much more even application to your lungs. So if that's not saying switch a patient to spontaneous mode, what if they're on paralytics? What if they're really, really sick, right? No, this is just saying, hey, in the world's most optimal place, spontaneous breathing counts, and it does, right? So spontaneous breathing, is, believe it or not, is actually better than mandatory breaths when we're talking about it, because the patient is pulling that medication in, and it's allowing for more even distribution compared to positive pressure, which just forces it the path of least resistance. Volume controlled CMV is better than pressure controlled CMV when it comes down to this. So volume distribution is a lot more even than pressure. So that's where we're seeing that there. The tidal volume should be enough to clear the dead space that we have here, and that should go without saying, but there it is. The respiratory rate, the lower rates will improve delivery. Well, why is that? If someone is breathing 10 times a minute versus 60 times a minute, they're going to get a lot more of it because they're going to spend a lot more time. Right, they usually have a longer time constant. So when that happens, we're going to usually be able to have more time for that medication to be delivered. They're not exhaling nearly as much. Another way to think about this, try to breathe really fast right now. What are you doing? You're exhaling quite a bit, right? You're exhaling quite a bit when you're breathing fast. So if I'm spending most of my time exhaling, what happens to my inhaling time? Right? Time yourself with how long it takes for you to inhale when you're breathing fast compared to when you're inhaling when you're breathing slow, like a rate of 10. Right? You're going to have a much longer inspiratory time constant. You're going to be not exhaling that gas nearly as fast. So that gives the medication more time to deposit, more time to distribute when they have a slower respiratory rate. So this isn't saying, hey, give the patient a paralytic every time we nebulize something. No, this is just saying in an optimal situation, a slower rate is better than a faster rate for particle deposition. So inspiratory time, the longer the inspiratory time improves delivery. This goes back to your SMI technique for small volume nebs that you learned in therapeutics class. What happens, right? You take that slow deep breath in with the nebulizer, pause, and then let it out, right? Same thing here. So the SMI, in theory, with mechanical ventilation, a longer inspiratory time should help, in theory, with particle deposition as well. The inspiratory waveform might be better to have a decelerating ramp versus a square or continuous waveform. Why a decelerating ramp? Well, the decelerating ramp uses lower peak airway pressures, so advantage there, but it has higher mean airway pressure. Good, we have better time to distribute that pressure. And then we have more even distribution of gas. So if you remember us talking about that with how a breath is delivered, you have more even distribution of gas with a decelerating ramp waveform. So in theory, the better way to deliver that breath would be in a decelerating ramp if you had to pick. All right, MMADs and more, right? So MDIs, meter dose inhalers, and small volume nebs usually have a mass medium aerodynamic diameter, MMAD, of 1 to 5 microns, right? That's on average. So we may need on an MDI dose to double it on compared to a non-vented patient. And the big thing here is why. Well, we can't say, okay, sir, madam, on the ventilator, right? When you take a breath in with the machine, you just hold it, right? You just take a deep breath and you just hold it, right? No, it's not going to work very well. Your timing is going to be very hard with these patients that are under sedation. They're going to be anxious. They have a tube stuck in their throat one way or another, right? So there's a whole lot of stuff going in there. So the big thing is that technique. It's going to be tougher to get that proper timing with them. So that's where it's that double the dose. So if they're ordered for 2 puffs traditionally for spontaneous breathing patients, then with mechanical ventilation patients, they would traditionally double that dose because of the technique. Lower flow and respiratory rates help with deposition. We already talked about that. They'll have a longer time constants. Lower flow rates means they'll have a longer inspiratory time, less like that SMI technique that we were talking about before. And slow respiratory rate means that they're not spending as much time switching over or cycling over to exhalation. Therefore, that medication has more time to dwell and to stick into the walls of the airway, so that way it's taking impact or taking effective medication administration there. Inline chambers, this next point here. Inline chambers for spacer adapters are placed proximal to the airway. So if we're looking at MDIs, right, we're going to place it proximal to the patient's airway. And your hospital might have a different policy and procedure on this, so always check with that hospital's policy and procedure, but somewhere proximal to the airway so we can time that. Some may place them on the inspiratory limb. In the inspiratory limb, like that picture we were talking about a couple of slides ago. So the big thing here that I strongly recommend, like I say, follow your hospital's policy and procedure, right? Above all, right? But with the inspiratory limb, if you're leaving it in there in place and it expands during delivery and then collapses, you may not need to do a short self-test. However, I recommend whenever you're adding anything before the Y, whether it's the inspiratory limb or expiratory limb, if you're adding anything in there, do a short self-test. That's where you re-SST the ventilator mode, so have someone bag the patient. Because when it goes back to what we started off with compressibility, you're adding extra stuff in there. So does that change the ability for the circuit or the ventilator to deliver its tidal volume? Yeah, the compressibility will change the amount of tidal volume the patient gets. So you could be having a change there. So I recommend if it's going to be a big spacer that you're just going to leave in place and it stays open all the time, maybe consider doing a short self-test to make sure you're not robbing the patient of tidal volume that they should be getting. So there's pros and cons. The pros is it allows less medication to be exhaled, right? It charges that circuit before the breath is delivered, so that would be a pro, putting it on the inspiratory limb. The con would be that potential for the patient being robbed of tidal volume if you don't have a short self-test, or if you don't have a proximal sensor like the Hamiltons do, where the flow sensor is right there. The pneumotac, if you will, is right there. So the best position, according to the book, the best position for an MDI is 6 inches from the Y connector. 6 inches from the Y connector. So this would be on the inspiratory limb, right? Does it make sense for it to be on the expiratory limb? No, right? So it would be on the inspiratory limb. So here are some pictures of different inline devices. Letter A up here is looking at an inline device where you just put this little tiny adapter in there. There's no spacer, but just this little tiny adapter where we can just connect it up and go there. Letter B here is an elbow device that's used at the Y. So this is at the Y, so it's not charging it. The risk here is potentially the patient exhaling most of that medication. It doesn't really charge it. It doesn't have any space for it to build up. Letter C here are these collapsible chamber devices. They're pretty nifty. I've never had to use one. The hospital I worked at never used these devices, but they seem pretty nifty to me, right? Your mileage may vary, so keep that in mind, right? My experience is not strong with this, but you would expand it for the medication delivery, and then it would accordion in and collapse when you're not in use. So therefore, you wouldn't have to worry about as much of the compressibility factor compared to letter E. Letter E is just a solid device that sort of stays in there, right? So one collapses when not in use, and therefore shouldn't change tidal volume delivery much. But letter E is a chamber device with an aerosol, and it's directed retrograde into the ventilator circuit. So therefore, it's back of the inspiratory limb. It's pre-Y, right? Here's your Y over there. So that it's pressurized, so it should help charge the MDI and make sure they get most of it. And then letter D is just a chambering device in theory that you could use as well. So you have different options here. It just depends on your facility and what they deem is appropriate for that place. What are some patient-related factors that we have to worry about? Well, secretions in the ET tube, or if there's bronchospasm that opposes the delivery of the medication. If there's secretions in the ET tube, how much medication can we get past that obstruction of the airway, right? Have you ever been stuck in traffic with there's an accident up ahead, right? It's sad that there's an accident, right? It's sad that there's an accident, but what happens to the amount of cars getting through or past that accident? That decreases because there's an obstruction in the roadway, right? There's an obstruction. So how well can things flow when there's an obstruction? How well can we deliver gas past an obstruction, right? It's not going to be optimal. So secretions in the ET tube, or if there's bronchospasm, our ability to get gas and aerosol through those obstructions is going to be diminished, and that can oppose the delivery and therefore not get as much medication as deep as where it needs to be. It's unfortunate, right? So that's where we could have diminishing effects of nebulizing for those patients with high obstructive issues like secretions or bronchospasm. The COPD and air resistance may be better at intermittent inspiration delivery versus continuous delivery. Some of these ventilator modes, some of these nebulizer modes, some of these modes that the ventilators may have on them has what's called an intermittent option, where it only nebulizes during inspiration, during inspiration, during inspiration. I remember the 7200 from, now they're called Medtronics, but they were called Puritan Bennett way back in. But there was an old ventilator called the 7200. If you want to go Google image that, have fun. That sucker would nebulize on inspiration, inspiration, inspiration. So it would be an intermittent mode, right, on inspiration. And that would help, because now what happens when your expiratory time constant, when you have high raw, can you exhale very fast when you have asthma or COPD? No, right? When you do a peak flow meter, right, you're trying to see how fast someone can exhale, get the gas out of there. So what about on a ventilator? Can they exhale very fast? No, they have a long expiratory time constant. It takes them a long time to empty their lungs, right? So when you're nebulizing something, what happens to all that medication that's nebulizing when they're exhaling? It gets wasted. It goes to the expiratory side of the circuit. It doesn't go to the patient. They don't get the benefit of that. It goes to the expiratory side of the circuit. So therefore, what really happens with this patient? Are they getting as much medication as they should? No, because their expiratory time constant is pretty long. So you can see why, hey, if you were able to switch, if someone has a high obstructive issue, if we're able to switch it to an inspiration only, that could potentially get the patient more medication, and less of that medication could be wasted if we give it intermittently, like on inspiration, versus a continuous nebulizer that runs for 10 minutes and then we turn it off because it runs out or whatever. Another factor to think about here is auto PEEP or intrinsic PEEP, sneaky PEEP, occult PEEP, any of the above, right? Any of those terms of above. And asynchrony can interfere with delivery, because what's happening? They're got to work past it. Can they exhale all that gas? No, there's a bunch of pressure built up, or they're working against the machine. It's going to interfere with that delivery. What about things about the ventilator circuit? So the ventilator circuit, the first one on here is an ET tube. So we want to look at ET tubes for an adult patient. Greater than 7 are better. So the smaller the tube, the harder it is to get gas to flow through it, right? That's Poiseuille's law. The smaller the radius, the more it resists flow and increases the amount of pressure it takes to deliver the same gas. So, right, when you're kinking off a garden hose, you have a garden hose and you decide to kink it off. What happens to the flow rate that's coming out of the end of that tube, right? Out of the end of that hose, what happens to the flow of water? It decreases, right? It diminishes. So if we have a bigger endotracheal tube, more gas can flow through there. Therefore, if we have a bigger tube, we can get more medication through there more easily, right? So an inner diameter between 3 and 6 millimeters can reduce deposition. So in your pediatric patients, if they have the really tiny tube for their size and we're trying to get that medication in there, that could be a factor that's working against us, is how small their tube is, right? And that just goes back to physics, right? Heated humidification is this next bullet point here. With heated humidification, it increases particle size, right? If we're trying to get an MMAD, a mass medium aerodynamic diameter that's appropriate for the deposition we want, and we're adding humidity, what happens to the particle size? It gets bigger, which means it gets either rained out or deposited in a larger airway where it wasn't supposed to be deposited, right? It's in PSCC versus simple cuboidal or simple squamous, right? So when we're looking at this, that humidity from the vent circuit could reduce the amount of delivered medication. So some places may not mention it at all. Other places, like when I practice, we would pause the heater, right? We had these heaters that were heated wick humidifiers. I'm trying to avoid saying specific name brands out there, but they were heated wick, and it had a feature on there where not only could we change the humidity level, but we could pause it and set for how long we wanted it to pause for. So let's say I knew my nebs ran for 15 minutes. I can press the pause, have it timed for 15 minutes, and then it would start back up again on its own. I wouldn't have to start it again. I wouldn't have to worry about forgetting to start it up again. So that's something that I could do. Other places, the risk versus benefit, the risk of you not turning the heater back on and having the patient plug off and have cold, dry gas being delivered might be too great compared to that potential extra medication delivery. So they might not want you to pause the heater. They might not want you to do that. So be aware of that policy and procedure. Just understand that they might get less medication because we have that heated humidity going on because of what it does to the aerosol size, right? It makes it larger, therefore rains out earlier. Bypassing the humidifier is not recommended for most machines, especially because of not remembering or forgetting to put it back in place, which could be very disastrous, especially with mucus plugging. Neb between the outlet and the humidifier may improve delivery, and I have some pictures of this. So the nebulizer between the outlet and the humidifier, between the outlet and the heater, right? The ventilator outlet and the heater, right? We're not talking about the electrical outlet, right? Where the gas comes out of the ventilator and gets delivered to the heater, and then from the heater to the patient, right? So in between where it comes out of the ventilator and it attaches to the heater, that's there. And most places where you put the vibrating mesh nebulizer, Aerogen, where you put the vibrating mesh nebulizer, right? That's where that would be, right there. So it's going to help improve delivery because it helps charge the circuit. It helps all those large particles that are going to rain out automatically. If it is a long therapy, don't give dry gas that long. Let's say we're using continuous nebs that are just running hour after hour, so on and so forth. That dry gas is going to cause more risks than benefits. I'd rather have some of my medication rain out than have the potential risks associated with mucus plugging and further bronchospasm with cold air being delivered. What about Heliox mixtures? They might improve deposition, but be aware if the ventilator can perform this function without being destroyed. Ventilator is a high conductor of heat, and especially the expiratory side of the ventilator, if it has certain metallic components, especially microprocessors, things that read the gas back at the ventilator that the patient has exhaled, it can destroy it. So make sure your ventilator, if you're using a Heliox mixture, can accommodate Heliox. In other words, if it's approved for Heliox administration, right, before you start hooking this up and playing cowboy. All right, what about MDIs? There are fewer problems with MDIs than with small volume nibs, right? We're not adding extra flow to the circuit. As long as you have good timing, that's the big thing. So fewer problems than small volume nibs as far as MDIs. With spacer, it's more efficient than using a nebulizer, delivering a bronchodilator to the lower respiratory tract. So as long as you're using a spacer and have appropriate technique, you're good on this, right? This can be very good. Remember, up to 98% that we were talking about earlier. So it could be very, very potentially good. You just got to make sure you got the right technique. And does that, the question I have subsequent to that is, does that technique change when the caregiver changes? In other words, you might be the best in the world at this, and let's just say you are, right? You are the best at this, but, and you believe in your coworkers, but is it possible that they might not always get that same concentration? They might not always get that same excellent care, right? Something to think about. You might need a higher medication dose, like 4 puffs of albuterol versus 2 puffs of albuterol, because of that technique and timing. Shake it. By shake it, once again, I feel like I need to clarify. The MDI, right? Shake it, right? Shake the MDI. Remove, place in the delivery device, remove the HME adapter if it's before the HME. If it's proximal, in other words, the HME is behind where the MDI adapter is, you might not have to do that. Coordinate the actuation of the MDI with the beginning of inhalation, just like you would on a spontaneously breathing patient, right? Try to monitor there. Wait 20 to 30 seconds between actuations, right? Allow for that medication to redistribute in the container there. And then monitor the response, right? Make sure their heart rate's not going up. Make sure nothing else is going crazy. So make sure you've given all your 4 puffs. Monitor your response, reconnect the HME, and then document, like I said, most of our career is documentation, but document that outcome once you're done with it. What about small volume nebs during mechanical ventilation? They're more commonly used for mucolytics, antibiotics, prostaglandins, and surfactants, especially prostaglandins when we talk about pulmonary hypertension. But the big thing here is to be sensitive to the patient. What do I mean by that? If you're using a pneumatically powered small volume neb, right, where it adds extra flow to the circuit and the ventilator doesn't have a mode where you can say how much extra flow you're adding. Some ventilators, they have a little neb mode, right, where you go to the nebulizer mode and you tell the ventilator how much flow you're running the nebulizer on. So let's say it's 7 liters per minute, because 7's a nice number there, right? 7 liters a minute, that's what you're running it on. And so now it knows there's extra flow added to the circuit, so it doesn't have to worry about the sensitivity. It knows there's extra flow, and therefore you don't have to worry about the patient being unable to trigger a breath or working harder to trigger a breath. So be aware if there's a neb mode and you use small volume neb, pneumatic powered nebs, that's something to utilize as well if you can. But let's say you don't have that mode or don't know about it, right? Let's say you don't have that mode. Well, then you got to worry about the ability of the patient to trigger a breath. Because let's say there's flow trigger set at 2 liters per minute, and you're adding 7 liters to that. So now they have to trigger a spontaneous breath, they have to pull in, instead of 2 liters, 9 liters per minute, right? That's a lot. That's a big ask for someone that's already in respiratory distress, right? A big ask. And so that's one of the issues that you have to worry about, is asking them that big work of breathing effort, is that worth it, right? And so that's something that you got to be very careful of, because that could cause a lot of asynchrony with that patient. These may cause high volumes if you're running pneumatic nebulizers, because what are we looking at here? We're adding extra flow to the circuit. Well, flow in I time equals tidal volume, right? So when we're looking at that extra flow, we can make for higher tidal volumes. You're like on an adult patient where we're adding, 50 to 100 mLs, that may not make a difference. Okay, we can debate that. But what about on a neonate, where the tidal volume might be 3 mLs total, right? If it's 6 mLs per kilo and this kid's 500 grams, right, and their total tidal volume is 3 mLs, right? Very small tidal volume. Can this make a big difference? Oh yes, Totally can. What happens to pressures if you're adding extra flow to the circuit? What can happen to the amount of pressure it takes to deliver that breath? What does that mean to the patient's lungs when you're using more pressure on the machine to deliver that breath? Could that be causing potential harm? Absolutely, right? Hippocratic Oath, first, do no harm, right? The apnea alarm might not be activated because it says, hey, there's additional flow, and it's from whatever source there is. It could be the patient breathing, so I'm not going to alarm. So the patient goes apneic in their spontaneous breathing mode. The vent may not know that they're not breathing. Does that sound like a potential bad situation? Absolutely. So that's another learning point for you. Hopefully you learn it here versus by experience. Don't leave the room, especially when you're doing a procedure. So don't leave the room, be set an ebb and run out, right? So the apnea alarm may not activate. What happens if you weren't in the room? Patients not breathing, how long were they not breathing for, right? There could be a lot of very bad situations. And they can alter the FiO2. It depends what source you're running it from. If I have a neonate on room air on the ventilator, and we're running it at 100% oxygen for our source gas, can that cause harm to that patient with their eyes, with oxidative lung injury? Oh yeah, absolutely. Can that cause harm if we have a patient on 100% oxygen and we're running it off of room air and diluting their FiO2 and causing desaturation, which then could be causing acidosis and causing hypoxemic brain injury or hypoxemic changes on their EKG, right? Throwing PVCs. Yeah, there's a lot of issues there. So that's where you have other things like it could alter their FiO2 depending on if we don't have a concentrated gas source that's appropriate for it. And some ventilators that have a nebulizer mode might have a little outlet where you plug the nebulizer into it, right? You connect it in there, and it nebulizes on inhalation if you want to have it on intermittent, and it delivers the same FiO2 as the ventilator. Good deal, right? So know your machine, know your equipment. So using a total volume of 5 mLs is recommended because what happens is something called dead volume, and we talked about this in pharmacology. Dead volume is the amount left over at the end of the nebulizer that just doesn't get nebulized, right? It's just stuck there. It's not going to aerosolize, right? Have you ever made popcorn and then have all those kernels that are at the bottom of the bowl? Right? That's dead volume, right? There you go, right? Next time you make some popcorn, if you're listening to me and eating popcorn, yay, right? And if you're not, go make some popcorn, right? Eat some popcorn while you're listening to this, right? So, you got to have something to entertain yourself listening to this. But during that dead volume might not be delivered. So by adding extra volume to that nebulizer, less medication will actually be left over. Because you're diluting it, less concentrated medication will be left over. So if anything, put more than 3 mLs in there, put closer to 5 mLs, and that will help make sure the patient gets most of that medication. Also here, you want to make sure that you position the small volume neb proximal to the humidifier. So placing it proximal to the humidifier allows for that gas to be not only mixed in with their humidity and aerosolized, but it also allows for the nebulizer itself to be a stable platform. It allows it to be stable because what happens if you place it proximal to the patient in the inspiratory limb somewhere? The patient moves around, the bed moves around, the circuit moves around, right? There's a bunch of movement. Is it going to be dependent, right? Are we going to have the uneven nebulization with all those different moves, right? So there's another factor of stability if we do it there as well. And then they have done studies looking at different ones, especially the vibrating mesh nebulizers, working more efficiently being proximal to the ventilator before the humidifier than proximal to the patient. Another thing that looks at here, high flow rates will lose more medication to a longer expiratory phase. So decreased flow rates are better, however, understand this is your patient situation overall. It's just saying, hey, in general, a slower flow rate, just like your slow inhale technique with a nebulizer, you want that to be as close as possible in theory. So are you going to be changing this every time you do a nebulizer? Maybe not, right? But it's just saying that would be the most optimal way to do it. The external flow rate of the nebulizer should be anywhere between 6 to 8 liters a minute is what's recommended. That's why I always said 7, right? That's what I used because, nice, number there, I guess. These nebs may last 20 minutes if they're intermittent, right? We talked about intermittent previously, where the ventilator just does it on an inspiration. Can that take a long time? Yes. But is the patient getting more of the medication? In theory, absolutely. Right? When we look at this next point, continuous nebulization is recommended for a status asthmaticus. So someone's in a severe asthma attack. Doing continuous is more appropriate. We want to make sure as much as the medication we can gets in there, right? We try to get as much as we can as early as we can in there. Hopefully our other interventions are kicking in as well. The medications, do be aware, especially no matter what kind of medications you're nebulizing, they might gum up the expiratory valve or increase expiratory resistance and cause autopeep. One of my tricks of the trade here, you're seeing a patient force against the ventilator, they're working hard, and you don't really know why. Check the expiratory filter. It might be clogged up. You might have to change the expiratory filter. There might have been a lot of water in the expiratory filter if they had a lot of rain out in their circuit. Check that expiratory filter, especially if you've been nebulizing very thick medications, and you'll know, right? Super thick. Then look at the last one here. Small volume nebs can be contaminated and risk giving a patient infection. What happens to that nebulizer when we take it out of line, right? The neb acorn. What do we do with it? Do we rinse it and put it on the counter, right? What do we, to air dry? What do we do with it? Do we rinse it appropriately? Do people touch it with their contaminated hands while we have it air drying, right? So it's one of those things that it's a potential source of infection when we take it out and put it back in. It's almost as if it's a circuit break, right? So it's a risk for nosocomial infection. So the CDC does still recommend cleaning the nebulizer before every treatment. So that's why they say, hey, before every treatment, rinse it out, make sure you get all that dead volume out of there, all that stuff. Every once in a while, you'll see people just add medications to the whatever is already in there before in the dead volume, and that just builds up concentration and concentration and concentration. Not appropriate, because then you don't know really how much medication your patient's actually getting, right? You want to know how much your patient's actually getting. What about the ventilator powering it, right? Some power the nebulizer using only during mandatory breaths. So if it's in an SIMV mode or spontaneous mode, it won't nebulize during those spontaneous breaths, but it only does it during the mandatory delivered breaths, right? Some patients will only get the nebulizers when the inspiratory gas flow is high enough, right? So it makes sure, hey, if it's a very shallow breath, it's not going to deliver it, right? It's making sure that it's only going to give it when they're taking an appropriate depth of breath. The duration of the nebulizer flow changes with inspiratory flow waveforms, right? So we talked about this being a square versus a decelerating ramp, which are your two most common ones currently. So that decelerating ramp is going to be more continuous, right? It's going to have that inspiratory flow waveform is going to have a longer inspiratory time compared to a slower inspiratory time, a slow inspiratory time, a longer inspiratory time with a descending ramp compared to a square. Square, you're going to have a faster inspiratory time. It's going to be very short, and you're not going to have as much dwelling time, as much distribution time, if you will, with the square waveform versus a decelerating ramp. So others, ventilators, they'll nebulize with each delivered breath no matter what, whether it's spontaneous, whether it's a low flow rate, whether it's a high flow rate, square, ramp, you name it, whatever it is. If they're getting a breath, they're nebulizing it. So it just depends on the algorithm of that ventilator when they're creating that nebulizer mode. And then the advantage here is the ventilator uses the same FiO2 and tidal volume delivery. So we don't have to worry about their tidal volumes going really high with nebulizing using the ventilator's nebulizer mode. That's a good thing, right? We don't have to worry about the FiO2 changing for oxidative injury or causing desaturation or anything like that. What about using ultrasonic nebs and vibrating mesh NEBS devices with mechanical ventilation? So I'm partial here. I thoroughly enjoyed using these ones. They usually produce a good particle size, around 5 to 10 microns. They do not require a separate gas source, yay! But they do require electricity, right? So you have to have something to plug it into. But they don't require a separate gas source. They do not alter the tidal volume delivery or the oxygen concentration, right? They don't alter your FiO2s. They don't make your tidal volumes big, right? So you don't have to worry about that component. You don't have to worry about that component at all. MDIs, vibrating mesh nebulizers, and ultrasonic nebs are considered to be more efficient than small volume nebs. Right? So that's just saying, hey, small volume nebs, not the greatest, they'll work, but they're not the greatest compared to a small volume nebs. If you had to pick, right, of these, right, you'd want to pick one of these three here, right? It just depends on the facility you work at and their policies, right? So if it's a small volume neb or vibrating mesh, you want it proximal to the ventilator output and between the output and the humidifier. And then that should, in theory, deliver more medication to that white piece of the patient. And here's a picture of what I was just talking about. And here it is, yes, this is aerogen, right? So here we have the inspiratory limb from the ventilator, right? So the vent is back here somewhere, right, if you're looking at the picture. The vent's back here somewhere. So the flow of gas, and I'll change it to green here, the flow of gas is going this direction. Right, the flow of gas is going that direction. Here is the nebulizing port here where you put your medication, and this one's connected to a syringe pump, it looks like. So that way it will allow for it to do continuous nebulizer delivery. And then what happens is as the gas is flowing through this circuit, it goes to the heater and it's picking up that nebulizing medication, and then eventually it'll go out here to the patient. So it's picking it up there. So that's what it means between the outlet of the ventilator and the humidifier right there. So this undiluted medication can be injected directly through that membrane at the top here. Right, that's what we see here, that membrane at the top there. And it does not have to be opened. You don't have to worry about contamination. You don't have to worry about any of that stuff there. It keeps it closed. It gives an appropriate MMAD of about 4 microns. And then all you do here is set the amount of time that you need it to be nebulized, whether it's continuous or right, so on and so forth. So you set that time. So these are very handy devices. I really enjoyed their use as well. So what's the proper policy? What's the proper protocol? Well, first is identifying the patient, order, the need for the medication, suction to get any secretions. We talked about this just a bit ago. If there's secretions or anything like that, that can obstruct the ability to get that medication effectively to where it needs to go. So suction airway secretions if it's in the tube, right? Does this mean stab carina, go deep suction? You already know how I feel about deep suction. Go listen to that lecture. Place the drug in the nebulizer, add the diluent to optimal fill volume, which is usually around 5 mLs for small volume nebs, right? Place the small volume neb proximal to the humidifier. We just talked about that. If there's a nebulizer mode available, go ahead and use it, right? It's there. Remove the HME if there is one. Oh heavens, right? There better not be an HME present and a humidifier at the same time, right? That was in the humidity lecture. Go to that one. But use a flow of around 6 to 8 liters per minute. So 7 is going to be the big one. And watch for the patient triggering if they don't have a neb mode. But still watch for the patient triggering to make sure that they're able to trigger each breath and that they're not working harder to breathe, which could be a very bad thing. Adjust the settings as allowed, so don't forget to turn them back, right? So that just depends on the hospital's policy of adjusting the settings. So don't forget to turn them back. If you switch them to an inspiratory pause on the ventilator during volume control ventilation and you added an inspiratory pause with each breath, don't forget to turn that back off. Right, or back to where it was pre-nebulization. So that's a big thing there. If you turn the heater off, don't forget to turn it back on, right? All those things, right? So that's if you do those things. Monitor the patient after the therapy. That should go without saying, but I got to put it in there. And make sure everything goes back to where it was beforehand. And last but not least, document the whole procedure. If they start having a change in the heart rate by more than 10 to 20%, then we need to discontinue. If you start to see abnormal heart rhythms, right, you need to discontinue the therapy. What about nebulizing during non-invasive ventilation, right? You have someone on a continuous positive airway pressure or non-invasive positive airway pressure, right? Like biphasic or BiPAP, right? That's out there. So studies suggest that both MDIs and small volume NEBs can be used to deliver bronchodilators during non-invasive ventilation. So we can still use an MDI, or we can use a small volume NEB. But the greatest aerosol deposition on this form, right? Non-invasive, right? Non-invasive, we're talking non-invasive here. Non-invasive, the greatest deposition is placed close to the patient, so proximal to the patient, between the leak port and the face mask. It sounds like I want you to know this. I just put a star next to it. You should too, right? Between the patient, proximal to the patient, between the leak port and the face mask. Inspiratory pressure is high, in other words, a better deposition compared to a low pressure. And expiratory pressure about 5. So that's to make sure we have that continuous deposition in there as well. So can you do this to patients that are on non-invasive positive pressure ventilation? Absolutely. But in this case, instead of placing it back at the heater for the small volume neb, they want you to place it proximal to the patient between the leak port and the face mask. Did you hear me there, right? But MDIs also are going to be proximal to the patient as well. All right, how do we monitor their response? And I think this is our last slide here. When we're monitoring the response to bronchodilator, we want to look at what happened to their lung mechanics. What do I mean by lung mechanics? I mean, did their compliance change? Did their airway pressures go down? Did their PIPs, their peak inspiratory pressures, decrease? So if their peak inspiratory pressures decrease, that could be because their airway resistance decreased as well. In other words, the medication helped, right? That helped reduce the airway resistance. It helped open up the airway so there's less pressure to deliver that breath. That goes back to Pose's law, right? The larger the radius, the less pressure it takes for gas to flow through that radius. So that means our airways are opening up. Our plateau pressure. Did our plateau pressure change? Hey, if we were over distended because we're air trapping, what happens if we reduce that air trapping because medication got to where it was supposed to go? All right, our plateau pressures actually might go down as well. So we might have better compliance. Airway resistance. Did our difference between PIP and plateau decrease, right? The difference between PIP and plateau is trans airway pressure, or PTA, trans airway pressure. If the difference between our PIP and plateau increased, right, that means airway resistance increased. If the difference between our PIP and plateau decreased, right, let's say it's 40/10. I'm just trying to be extreme for a second here. 40/10 is a pretty big change there. It's a change of 30. But now we're at 30/10. Well, our PTA decreased, our trans airway pressure decreased, and therefore there's less airway resistance, right? Because our PIP went down here, plat stayed the same, right? Our resistance changed, right? So that means it's a lot easier for gas to get into and out of the lungs. Breath sounds. Are they still wheezing? Are they wheezing louder, right? Loud wheezing is good. A quiet wheezing with very little air movement, bad, right? You already know that. So better air movement, less wheezing, louder wheezing, right? So did their breath sounds change? Did their vital signs change? Did their heart rate actually go down because now they have relief from it? Did their respiratory rate, if they're over triggering, slow down, right? Did their blood pressure go down because now they're not having to work as hard to breathe? Did their work of breathing change it? It's not even on this slide here, but add work of breathing. Did their work of breathing change, right? Are they using as much accessory muscles? Are they sweating as hard, right? Diaphoresis, right? Did their work of breathing go up or down, right? Are they working harder or less? Hopefully less, if it took good effect. So vital signs and all sort of attach that to work of breathing there. Visual inspection, I guess. Graphs. This is our thing where we can actually see. On the pressure time scaler, did their pressures decrease and they're reduced to auto PEEP, especially if they're in volume controlled ventilation? On the flow time scaler, did they have an increase in their peak expiratory flow rate? So that's the distance here. So here is your flow scaler, and we'll just do decaying ramp. right? Did this depth change, right? If this moved down, that's a sign they have better peak flow rates. The other thing would be a shorter E time, how fast it comes back to baseline there, right? And if you're like, I don't know what you're talking about, go watch the graphics PowerPoint. Again, I do talk about it there with some examples in there. The flow volume loop, do we still have scooping on that expiratory waveform, right? And that was in that one as well. So did the scooping change? And then you can also see peak expiratory flow rate on that one as well. How deep does it go? And then on your pressure volume loop, right, do we have a hysteresis, right, where it's super wide, and then now it's getting more narrow? A lot of these ventilators will allow you to save a loop, and then you can compare it afterwards. So did we have a change there? So those are all things that we should be looking at pre and post, and that's something that can tell you, are we going the right path? Is the patient responding to this therapy? If they're not responding, is there something else that we should be trying, right? So this helps you be that integral part of the care team. So hopefully all these tell you, okay, giving a nebulizer or giving an MDI or giving any kind of medication to a patient, whether they're on non-invasive positive pressure ventilation or invasive positive pressure ventilation, has a lot of dynamics to it, right? It has a lot of dynamics to it. What's best for your patient, right? So think about this. This patient needs good quality medication delivery, but they already have high airway pressures. Well, if they already have high airway pressures and they need good airway medication delivery, am I going to pick small volume neb? No. I might pick a vibrating mesh nebulizer. I might pick an MDI. If I don't want to break a circuit because they're very, very prone to airway collapse and they have something like ARDS or something where they're already at risk, high risk for infections, they're immunocompromised, I'm worried about their ability to trigger breath because their respiratory muscles are so weak, maybe a vibrating mesh is where I go, right? Maybe those are all things that I need to consider going into this. I got my patient on non-invasive ventilation. Well, what if they're breathing really fast on non-invasive ventilation? Will an MDI really help me, right? Will I be able to have adequate technique and to time that breath with that patient on non-invasive? No. So that patient might be more appropriate for a proximal nebulizer in non-invasive, right? So you got to know your advantages and your disadvantages. Like I said, more dynamic than just your spontaneous breathing patient. But hopefully you have a little bit more clarity here. You can go back through this and sort of see from there.